Hello everybody, it's been a little bit since we've done Dental Learning Live. I think 2020 caused us to reflect on life, but we are here, we are better for it, and we're going to wrap up the 2020 year with Dental Learning Live meets sort of Zoom. Go figure. So I have a great case to you I want to go over today, and it's been a request because a lot of times if we want to adopt and learn new technology, sometimes it's really hard to incorporate it when you just practice real life. And sometimes the educations that we get trained on it, they don't show all the nuances of what we really do. And so from that perspective, we want to show what I can show you, I guess, for me, the things that are, frankly, the time consumers. And having used aspects of techniques and protocols and technology, I just want to show you what I do. And so I'm going to give you truly a top-down, A to Z, unedited experience that's difficult. And it's difficult because it consumed a lot of time, more time than I would say my average cases go. And then a lot of times that has to do with these deep, deep occlusal fillings. And as you see, what's going on behind me is I'm skipping over some of this stuff, but it's just a workup of, if I want to incorporate the GentleWave, for instance, I'm going to look at a cone beam from a unique perspective. Frankly, diagnosis is done. It's pretty obvious this tooth was started and provisionalized and basically a form of a pulpectomy before they sent them on over. The dentist performed that a few weeks ago, and the dentist is now, or the patient is now ready to seek treatment. And what I'm doing is I'm going through this, focus down here. I'm actually just checking general anatomy. I'm looking for anatomy inside a tooth, and I'm comparing it to what's going on. Those are some great big clean sinuses. No mucositis, there's nothing going on. I can identify canal spaces, but I can also identify constriction points inside these canal spaces. And when I do that, I'm going through slices in different thicknesses. And what I'm doing is I'm just sort of redefining the way I've thought through root canals from yesteryear. And frankly, I'm identifying pathway for fluid. I'm identifying what instrumentation protocol I'm going to do. I'm definitely going to identify short. Now, I will say when you try to measure on cone beams like I'm doing, they're never really accurate because you have to sort of line things up and measure sort of the slice in the center of the canal. And teeth traditionally are crooked. They're not straight like beams in a building. And so there's always a second curvature plane, which adds distance to our measurements. And so you can think of that if I wanted to measure for sort of from a perspective of apex locator and traditional terminus locations. That's different than if I want to measure grossly and sort of know that I want to err short, especially if I'm going to use some technology like fluid dynamics. And that's what I'm going to do. This is going to be a GentleWave case. You can notice that we do have some, an ovoid mesiobuccal root denoting an MB1, MB2, and isthmus formation in between. It's definitely, when you look at the MB2, it's got a hook that comes right at me when I do it. I'm just drawing some curves and some planes. And in this particular cone beam, I can do that in a couple of different perspectives, and that's actually what I'm doing here. So I'm just learning my anatomy, and it's very important of what I'm going to employ. From a time management standpoint, if you look at my little counter down here, this is true to form. And generally in my workup, I'm not going to spend a ton of time on it. I just, with experience, I can go through a study of a CBCT relatively quickly. And my emphases have changed. And I think for the GentleWave users out there, I think you know what I mean by that. If not, hit me up with questions. I'll be on the webinar that I can pause and answer any of my own questions or questions come up. And if I misspeak, call me out, and I'll correct myself likely during the actual live webinar. So getting the lay of the land, I can see as I go through on my orientation, I'm looking at my slices. I'm moving fairly quickly through the slices to, like I said, understand pathways of fluid dynamics, constriction points, bottlenecks, things of that nature. I used to spend, like I said, or I alluded to, a lot more time on measurements. That's not what I'm doing right now. I'm not so worried about measurements. I'm learning about the shape of the tooth. Just about done. What I'm doing is I'm kind of acknowledging the curvatures at this point. If I skipped over it, but if I go back in time, or you watch back in time to the 2D, it didn't measure very long, and it was in like the 15, 16 millimeter range, because projection radiography often foreshortens things. But in this case, the cone beam can also kind of play a little game of measurements on you too if you're not looking at the slices right. But what I've determined is, I'm down to bone level right here, and that's going to make it very hard when you think about it. I'm going to introduce a lot of factors to sort of a platform buildup. First factor is bleeding, gums, saliva. I'm kind of lucky that this is a maxillary second molar as opposed to a lower second molar. I'm not going to be fighting the tongue or such, but if I don't get a good buccal seal, I could be fighting the parotid duct dumping in on me. And so one of the things that I decided to do is just simply access without the rubber dam on. And I think you all know that. I don't want to tear the rubber dam. That's kind of a pain to have to redo it. So from an efficiency mindset, I don't want to work backwards ever. I just want to have a steady step going forward. And so for me, I'm using these surgical length slow speed burrs, or the Muntz burrs technically, and I'm just removing that IRM. I'm also sort of conscious, and at times I do this, I kind of make a decision down here of, man, should I use that IRM as sort of my seal? Clearly, they didn't get embrasure forms when they did it. They just packed it into the gums tissue, so I know those gum tissues are going to be roaring red. But maybe that would be an idea or a thought of, maybe I should just isolate with it in and run the GentleWave with that in. And theoretically, you could do that, especially if you thinned it out and left it as a kind of a matrix and then built the sound seal in front of it. But I don't necessarily trust that. There's entropy in that statement. There's things that are out of my control in that statement. So I chose not to do that. Knowing then the consequence would be I would induce bleeding when I got that out. But I was actually good with that, because something that I could control is a little product that a lot of us know, and it's called astringent, or ferric sulfate. And that's what I decided to do in this case. Identified the anatomy. I know I'm going to go to a ferric sulfate protocol, and inducing biological remodeling or crown lengthening at this point may be a good strategy for the dentist doing the crown. And this is a protocol I've practiced for a number of years, so it's very comfortable for me to want to just introduce this astringent at this point. I've learned that I don't dab, I scrub when I'm going to do that, and so this little tip with that tuft out the end is very important to burnish into the papilla, and don't shy away from the pressure that it takes to actually burnish it in. Therefore, you can truly control the environment. The last thing you want is it to sort of weep into us, especially when I'm trying to build up a platform with sound seal. So once I've done that, I am introducing the rubber dam clamp. Now, on occasion, I'll actually use a second material called caulking from Ultradent, or the putty from Ultradent, and I'll introduce that prior to placing the rubber dam, and sometimes I'll do it afterwards. Now, my decision tree, if I'm going to use that product before or after the rubber dam placement, is how well I think I can get a clamp on the tooth. In this, I thought it would be pretty intimate, and for the most part, I was right, but there is a gap that's developing between the rubber dam and sort of the floor of the tooth, and so I'm wiggling the clamp to see if that's going to cause movement of the rubber dam up and down the contact, essentially. And I'm going to see if I can actually sneak it down. And so I'm using my thumb, and I'm kind of pushing the rubber dam down. And when I realized I couldn't close the gap, now I'm going to introduce some caulking from the inside approach. Now, that might seem weird, but watch what I do. One other thing, I got ahead of myself. I'm actually injecting it into the clamp holes. And I get sometimes criticized for doing that. People don't understand that. But what it does is it pushes apical pressure on the rubber dam, and it gets more of a cervical seat when you do that, and that's why I kind of do that. Now, I'm just basically looking for anatomy at this point. You saw how I kind of put the caulking, gap filled the rubber dam, and now I'm just really in a good environment. From that former creosote kind of pulpectomy approach that was done, the pulp was very stenotic, and I was poking it with an Explorer, and I went right to a rotary Explorer and decided to just see where it was and also get a feeling for like if there was decay or stone formation left there. And I'm actually just feathering this with that Munspur, and roughly, frankly, what I've decided is they didn't remove all the secondary caries dentin. And so I'm just sort of removing any of that reparative, reactionary type dentin, and I want to find that I can, find something truly that A, if I'm going to do a restoration, something to bond to, and B, I want an intimate contact with the sound seal, and those are important details. And so here we go. Let's take a look at that after I've kind of done that. Let's see if I can focus in on it. I can see that I still, have some issues there. And I'm seeing if I can get anything to bite into the anatomy. And so that's just actually a universal SX. Now, I'm not actually trying to enlarge that cervical zone. I'm actually just trying to see if I can get through any of the obstructions and create a pathway for fluid, since that's sort of what my goal is, and kind of what my practice has gone to is fluid first, filing second. And that's the mentality that I've sort of described. So feeling pretty good that I have good access, good visualization of everything. Kind of preliminary fluid prep is with EDTA, making sure that I've got nice clean walls. This EDTA kind of helps remove the smears we know inside the canal, but it also helps us inside an access. Clearly, this is all prep work for sound seal. And these steps may seem redundant, they may seem like an overkill, but again, in my experience, it makes the sound seal platform bulletproof. Now, I'm 13 minutes into when I started anesthetic on this case, and that was before I went up and did my second read, technically, on the cone beam. And again, I was just kind of going through the motions in the protocol on the cone beam just to kind of let you know and get everybody on the same page of where my mind is kind of going to this. If you look up here, you'll see how I'm working with my staff, how they pass me instruments, and that you can see that nothing's gamified in this video. Like, it's truly true to my environment. Now, once I know I can get into these things, I'm going to start going with as small as instrument as I can. This protocol instrumentation technique has actually changed, but this is a 1504, and frankly, I can't wait to never use a file again, but I'm trying to do pretty much everything I can now with just the 1504. My mind doesn't necessarily count an SX or my ability to find the orifices, because they're just explorers and I'm just trying to get orientation. Sometimes I can't get a 1504 in. I have not hand filed yet, but I can't get it in because there's too many obstructions and calcifications in that coronal third. And sometimes I'll have to jump up to something with a little more metal in the file, like a 1506. But I really don't want to go beyond those two instruments. And like I said, if I had my way, I would love just to sneak in a 1504 all the way through. Now, you could achieve that with a lot of hand filing. The problem with that is time. It's a time killer. And I think 1504 is still a convenience form we need minimum for fluid dynamics. And so I know I can't be less than that, at least the protocol as it stands today. And once I've established those, coronal third removal of debris and obstructions, then I find that my 1504 will advance further down into the canal. And mind you, if you go back and review the cone beam, I knew I was in there were certain bottleneck points. There was a bottleneck right here at the cervical third of the MB, and then actually where it bent, there was another bottleneck where the 2-to-1 formation kind of came in, and really on the cone beam, it just went to like blockage. So I was working down to that point. My estimates on these lengths are roughly 18 millimeters. Now, truly, if I were to measure it properly, and sometimes hindsight's 20/20, I know I'm in 20 millimeter roots. But with the conservative nature and also the emphasis of fluid dynamics, I don't want to go into that kind of terminus zone just yet because of the possibility of the concerns of the critical anatomy of maxillary sinuses, especially really clean maxillary sinuses. And that's a big deal considering the inversion we have going on in Utah these days, and there's a lot of pollution that frankly causes a lot of mucositis. That's neither here nor there, at least it's not COVID. Well, what I just did is I injected that caulking in, told you I was acknowledging that gap, and now it's time to close the gap. I'm not gonna have a perfect seal to run the GentleWave like I was working with just basically hand irrigation. And I do this right before the sound seal formation because, you know, this product that I'm using kind of expands like a baby's diaper when it gets interacting with fluid, and so I just wanted it to be a dry barrier. And so I placed it, used a perf paddle to kind of tuck it up underneath the rubber dam. I took a bendy brush, saturated with isopropyl alcohol, and just burnished it in and removed all the sort of flashing and debris. And I just wanted to make sure that when I went to this step, it was going to touch dentin. Now, it's not conditioned dentin, although that is a great trick, but it's at least EDTA conditioned dentin, and that actually makes a difference. You can see that I used a tip to place it, and I'm using that same perf paddle, and I'm just sort of almost like plain, you know, baker cake decorator with this stuff, and I'm just sort of drawing it up, and I'm trying to make the access wall where I think it should be. And also what I've learned in discussions with Mirzad Kapoor and also with just my own experience, that the more smooth I make that wall with less sort of bumps and grooves and things like that, the better the ability for fluid dynamics to occur. It's a better environment, it's a better chamber. Now I'm not talking about a divergent chamber, I'm just talking about a smooth walled chamber, and it does make a difference, turns out. I'm trying to always think in terms of setting myself up for success when I want to incorporate fluid dynamics. And now that I did that, the walls are nice and smooth. I've got an access that's 3 millimeters or greater. I am coming in a little bit of an angle. I'm not coming straight down the center of the tooth, and because of that, I know that I got to actually shift my platform towards the mesial, and that's also important because I want that sound bar to stay as centered as possible. So because of that, I leave a breadcrumb and into the access chamber, which is what I did. I encapsulate the tooth so I can kind of see where I'm going, and then I incorporate the matrix that's sort of covered with more sound seal, and as I'm lining it up, like I said, I'm airing towards the mesial. One of the reasons why I preset the sound seal, so it wouldn't just kind of smush all the way through the contact. And that's all it is, folks. Like, it isn't that difficult. You just have to take the time to pay attention to those little details. But as you do it, it's not that hard. In fact, removing the decay and setting up for the restoration is also what I did. So I'm killing 2 birds with 1 stone. Curing it, checking it. It's very important that this sucker isn't bouncing. You can see that they're doing another cure. I felt it was a little tacky. Sometimes I'll touch it with my glove, and if it leaves a little smear on my glove, like it sweats on it, I'm going to give it another hit with some light and some heat. But if you look at where that window is on the matrix jig, it's really coming over the occlusal side of here. I mean, that's over the embrasure or the distal marginal ridge of the other tooth, the first molar. Popping the cork. And again, I did that to try to keep the sound bar centered right on the occlusal floor. I don't want it like directly above like the distal canal, which would be almost the de facto approach to the way that access was. I'm taking high speed throttled back. If you have an electric motor, you can turn it down if you really want to do that. It's a feathering approach because sound seal's soft, and so you can gouge it and remove too much, which is sort of not bad for the tooth because it's just sound seal. That mesial wall was already missing. But it's very easy, line of sight wise, through the microscope to see the distal wall, but I just don't want to really touch dentin at this point. And so that's all I'm doing is I'm refining that, and clearly I'm trying to pay attention to these details, certainly because I'm making a video of it. And then every once in a while, if you find like air bubble defects, that's going to happen. And so there's got to be an approach to sort of fix that as well. And I use, or if I just feel like there's like in a bubble somewhere, and or if that's just like a cusp tip that's coming through, I'll just kind of poke and feel. The sound seal's so forgiving, you can always add to it at any time. And what I'm doing here is I noticed there was a little bit of flashing down there, and I didn't want to keep like opening things up or at the risk of removing too much. I just went back to that Munspur and just sort of feathered it again, and I wanted to make sure that I'm closed down there at sort of the deep blinded spots. Meaning the mesial buccal line angle and the mesiolingual line angle. And once I know that I'm closed, man, I'm not worried about anything at this point. It just works. It's very, very predictable. Now, I know contraindication from Sun Endo was subgingival decay is a no-no. Frankly, because it's a pain in the butt to isolate, and how can you really control that? Well, I just showed you how you can really control that. I'm 23 minutes into this case, taking this into consideration, and frankly, that's long for me. Normally, I want to be under 16 minutes at this point. I always have a time clock going on in my head, and I only do that for training, even myself. It's the way that I know how to keep on schedule, because nothing's more frustrating when you can't keep on schedule. Now, getting the depth, as you all know, the game of that sound bar, it's truly, get as close to the bottom of the floor as you can without touching, because I don't want to rattle that tooth. But it's more effective the closer that sound bar gets to the floor. So I use the jigs. I like the scratch and feel approach, not the scratch and sniff, but the scratch and feel approach to do that. If I hear any feedback, if it's like chalk, your fingernails on a chalkboard, then I know I got to go one size smaller. That was a blue, which corresponds to the seal, the cap. And as you watch this degassing environment go through, this can kind of be a little bit noisy right here because there's a lot of activity. This is the exhaust pathway. But as I look along the walls here, or even through the window view, I'm making sure I truly have a degassed environment. It's very important because that's where I'm most effective, in that kind of environment. And that's what I'm doing. And I think the intended audience for this was truly users, so you know the dynamics of what's going on with the advanced chemistry, the fluid dynamics, the cavitation, the sound waves, et cetera, et cetera, et cetera. And this is going to run its protocol. Now, I did use selected as a vital case. Now, you didn't notice much bleeding, but frankly, that's because it was formicresol-induced pulp. And that's very stenotic, and it's very dense, as you all know. It's very stenotic, right? And that means our fluid dynamics is going to get worked because it's in the way. It's a true obturant. And I also knew the files took a beating just to get this thing started. So it'll be interesting to see what my fluid dynamics really do in a minimally filed, instrumented, all those words that we throw around, canal space shape that you're trying to create. The problem with all those words is it's not actually true to form to fluid dynamics, because I'm not trying to shape the walls. I'm not instrumenting in the sense of step back, crown down, all those philosophies that I learned in residency. I'm actually just trying to get into the dang thing and making sure I'm going to have enough opening for all the principles of fluid dynamics to work of the GentleWave. And because of that, I will pay attention to certain details. One detail, if I've gone too far, or if you've practiced instrumentation to the terminus, and I'm sort of in a high-risk case with no buffer out the periapex, being bone marrow defined as, or being mucositis or granuloma, basically endopathosis. It's kind of a buffer, frankly. Instrumentation is less critical, but this is the most critical in my mind, vital, and then of the vital, it's most critical when it's stenotic. But what you can do at any point, if you think you were too aggressive on your instrumentation and you're worried about fluid breachment occurring at any point, you can always throttle up off your rheostat and look for puffs of pink stop, pause, start again. Don't even have to lift the PI off the sound seal. But you'll see blood coming out. When you're in an environment that frankly is not bleeding, and you've instrumented and frankly is not bleeding, you know you're removing pulp, it's unlikely to really bleed until you get to the terminus. And if you're going out or you're worried about pulling something in from the extraradicular environment, it will talk to you a few minutes into the EDTA cycle, or excuse me, the sodium hypochlorite cycle. And so you can always safety stop and check your work or keep the patient safe at all times. Of what you saw of this sort of modified workflow approach to things, I frankly don't have a problem, very rarely. And even though it was considered high risk, I've done it enough to know that I only instrumented to the mid-root. And sometimes you can be criticized by that, or it can cause a problem on obturation. But I'm really comfortable with how to address those situations. And we'll see if that's actually going to happen for this case. But we'll just live and learn. So we're still going through the protocol. And I'm going to speed up this video, frankly, because I'm running out of things to say. Again, stop me at any time and ask questions, and I'm happy to oblige. But I'm just going through the protocol. All I'm doing is hitting fast forward, and we'll take it to my endpoint. We'll see. So the magic questions are, did the GentleWave do what it said it was going to do? Did my sound seal withstand the energy of the GentleWave? And what did it do to that kind of deep mesial class 2 caries induced subgingival decay, et cetera, et cetera, et cetera. So onward and upward, right? 30 minutes into it, and some change. Now, if you look at the top of the screen, up here, you'll see my assistant doing her notes. And frankly, that's a great time to either do, the other tasks of an office, as I'm trying to always keep an hour workflow, and I truly do, even in this, for instance, have a patient that's going to be seated and started next door. But I've learned to get all my homework done with my assistants, calling out any details, and you'll see her go over and make those notations at that point. All right, let's go a little bit faster. You'll see her probably bouncing around here a little faster as I'm speeding up the protocol. You got to kind of sometimes learn to be a little bit funny when you're doing this, because you can see we're having dialogue. A lot of times I'll re-engage with my patients, that sort of stuff, and so on and so forth. It's kind of a nice thing. Now, I'm pausing here for a moment to show you the undercarriage. Kind of sped up a little bit too fast. I actually just removed it with my fingers. And for me, the sort of test of a good sound seal, although it is hindsight 2020, is if you can see the antaglio intact and you can see that class 2 wall, the antaglio of it, or the impression of it almost intact, and you can see that right here. You can see how that withstood the test of time, and that's the protocol. I mean, it's super easy when you think about it, yet we're here talking about it because candidly, we have problems with it, and the feedback is it's difficult. But I'm here to say that it's actually not difficult. It's just take the proper steps and just learn to be really efficient in those steps. So just kind of showing that off. And I'm 33 minutes into it. Now, if I look, I still have some little remnants of sound seal in there. You can leave them for the time being, but since I'm going to be doing a restoration on these, I'm actually going to, pick them out. There's no point in leaving them. I also am an advocate and sort of introduced the 3% sodium hypochlorite into the system. I always will check it to see if I have any blood flow. Now, that can tell me one or two things. Did it go to the end? That's one thing. Maybe I was shy, maybe it didn't make it to the end. Or, if it bled too much, it could be that maybe I went long and I have sort of this chemically induced agitated environment. which I would argue is not chemically induced, but it's definitely an agitated environment, and bleeding time sometimes can be a little bit of an issue. Now, as I did that little irrigation protocol, I noticed that as I took that out, I still had some sort of extraradicular underneath that class 2 decay coming back in. And that just speaks volumes as to the protocol that worked during the procedure, but it's still a relevant factor even after it's done. And so for me, I can always reapply, and I can always add more caulking, or what you saw me do. I just went back to the astringent and we just kind of went back to work. I'm putting in my working cones because of the sort of the questions that I just answered, or asked myself, like, well, where am I into the canal? I never yet have taken a working length in this protocol. And so I'm putting gutta percha cones in, and I'm going to take a little working length x-ray, frankly, because I've not really established anything other than instrumented to where I feel fluid dynamics could make up the difference. But I have this other problem. We live in a world where we still have to have some sort of convenience form and some sort of ability to obturate. And as I went up to that, one little oopsie happened. I crinkled my cones going in this, so I knew I didn't get down there. I liked where my distal was with a 15, and I had a 20 in the palatal, and it just didn't quite get to the end either. And so, the question is it the fact that I didn't instrument or plane the walls, and now I've got to make room for gutta percha, which is basically getting caught up into calcispheриtes inside a canal or whatever you think is going on. It's certainly not the glassy, smooth walls I was trained to do as an endodontist. But I'm actually going to take the rotary down to what I believe my length really was. And like I said, my estimated working length actually was in the 20 millimeter range on the mesials and on the palatal, and it was really kind of hard to tell on the distal. I did know when I looked through the cone beam that I was open on not the mesials because it had that hook, but I was open on the distal for sure, but I was not opened on the palatal and on the mesial buccal. They kind of just had that sort of blockage look. And so for me, I was relying upon fluid dynamics to sort of establish its form of patency from fluid dynamics. But what I did at this point is I wanted to confirm the idea in my head with a file. So now I'm introducing a 10 file to the workflow. And it's just a 10 file, and I'm actually, at this point, can go to a true terminus length if that's something that we find, or you might find still valid in your legacy bias, and that's up for you to decide. But I wanted to show you that my idea and the actual length was sort of verified here. I could actually get a 10 file to passively go, not a lot of twiddling. I could get it to go to the 20 mark on a calibrated file. By the way, this is a 31 millimeter 10K file. I'm not using it to instrument. I'm just using it to sort of be my length determination and figure out that I know I can get a 10 file to length. Now, clearly, the cones that I have in my armamentarium are a 1504, and that's actually bigger than a 10 file. But under the logic of fluid dynamics, and if it did what it said, then I can use a cone to sort of, spread the bioceramic sealer, which is my sealer of choice in this protocol, to go to length. And so now that I've done that, I decided that I had those constriction points in the middle of that 2-to-1 of the mesial buccal, and so I decided to actually instrument with a 1504 rotary file. I didn't choose to actually put it in the distal because I didn't feel like I needed to. That was sort of ready to play ball with where I was at. So using EDTA to ostensibly help remove any form of smear that it may generate, and then as you look in the canals, they still look really, really good and clean. And then I'm actually checking that my length and drying at this point with paper points, no excessive bleeding. Paper points are going to length. to the calibrated mark that I'm shooting for. So this is sort of my happy trail. So, you know, now it's obturation 101. They're just actually with smaller sizes than I've been accustomed to for a long time. Now, again, I've left this working length on screen, talking about those details that I tried to describe. And again, I crinkled those cones right there, so I kind of lost reference. I could have stopped and done another one, but I didn't. I just went through my workflow. You can see that I'm 42 minutes with all these little sort of calibrations and adjustments, but that's okay. My argument is I'm doing it at this point, but I would have spent probably double that time if I would have fought through all those details before I ran the GentleWave. In fact, GentleWave made it easier. You can see that as I injected in the 2-to-1, I injected just in the mesiobuccal. Sealer came up and around like a racetrack up the MB2, and obviously that's nothing new for a lot of microscopic trained endodontists, but it's still comforting knowing that it did what it said, because I really didn't shape the canals. This is a little bit debatable. I actually put in a paper point into the file, and my logic there, or into the MB2. My logic there is, if there was the racetrack story going on, I don't want fluid from the MB1 going through an isthmus into an MB2 and then just leaving that stagnant fluid in there. And so I like putting a paper point in to wick it out and then reapply sealer, get a fresh coat, and then just kind of go from there. As I was talking, I went and obturated the second canal. I'm doing them one at a time. It's not always the protocol. Some doctors, myself included, will do more than one at a time, but frankly, I am trying to make a video. So, distal buccal. Sealer, same protocol. I'm not really, I wouldn't say I'm really doing a kind of a continuous wave. I'm just sort of searing off where my heated element just naturally goes to. It's not at the orifice, it's just wherever it would go to. And then I do kind of cold vertical compaction at that point. Now I'm on the palatal root. Same thing. You can see my calibrated marks are lining up to the cable surface margin. I'm always checking references all the time. And, you know, we're almost done with obturation. And I am 44 minutes into treatment. Frankly, without all those steps, I would be done by now. And frankly, without making a video, I'd be done by now. Maybe not in this case, but in my average case, like the average protocols, and I show a lot of videos like that, but everybody says to me, well, that's where's the exception? It's not that way all the time. And I'm like, you're right, it's not. But this is the exception for me. This is the ones where you have all those little baby steps to do. But frankly, it still works in my hour protocol schedule. I am backfilling at this point, and there's nothing new to that technique. It's just a gun, injecting gutta percha. We could probably speed this up, but no need. We're just about done. And again, I'm always trying to be one step ahead of the game, and that is now that I'm sort of compacting the gutta percha in, I'm thinking in terms of, well, I'm going to now do a permanent filling. You know, you could have choices. Sometimes we're influenced by referring doctors. It could be a post and core, could be a core. There's conversation talks to that. Minimally invasive endodontics likely does not approve of the post. But, you know, other people are like, well, this is a great big deep class 2. Maybe they think it borrow strength from the root and give it to the restoration. I'm not subscribing to that, but candidly, you're going to have a story or a conversation with your referring doctor about that, and it's important to sort of always maintain that relationship or at least justify your position. Now, I'm not actually removing dentin. I'm just feathering anything that could be considered inside the axis at that point. And essentially, I'm using that instrument just to frankly clean, because it's a little bit more efficient than just a bendy brush and isopropyl alcohol, which is what I first use to just make sure that I got everything clean and the chemistry is out of the equation. After which, I will go to a double-step bonding agent, which I like. I like the conditioning agent, and frankly, I like it as opposed to a single step just because we're endodontists, and we just did a whole bunch of stuff inside that canal that regular dentists don't do. And so I haven't subscribed to the single step. That's my opinion. I like the conditioning agent working to my advantage to complement and augment a bond at this point, especially if you're bulk filling and if you're worried about C-factor, shrinkage in other words, and bulk fills. There's a fair debate with that, but I am using a dual cured, chemical cured and a light cured comprimer for my buildup, and I've used this product for well over a decade. I've had great success. My dentists like it when it's inside the crown, but when the patients don't go back for crowns, heaven forbid, it's actually withstood the environmental test of time in my practice of withstanding the abuse patients can give it when there's not a crown placed. I do, when I place it, I do scratch it along the floor because you can induce air bubbles along that, and that's always really frustrating when you're at the final steps and you see avoiding the filling and you're doing restorative dental work. It's kind of embarrassing. So I will scratch and drag like a paintbrush motion up all the walls, keeping the tip down, and then as it naturally starts lifting that tip out of the buildup, I will let it follow. I'm using my friend the Perf paddle. That is the paddle I use to pack the caulking underneath the rubber dam, or the putty if you like that product better. Actually, I call it caulking. I'm actually using putty to clarify for whatever reason. I just like to misspeak. I just call it caulking, but it's putty from the manufacturer. Anyways, pre-shaping, there's sort of this half-set state that comprimer goes to, which is really easy to then address the contours with and just sort of close the gaps of the junction between the comprimer and the tooth, and that's all I was doing. Remove the rubber dam, and as you all know, I'm going to clean up the mouth and adjust the bite. But because I promised this is not going to be a gamified video experience, don't ever like doing that because I like real life, the good, bad, and ugly with it. I'm 50 minutes unedited, and it also means I've got to then do the job of cleaning up those marks, cleaning up the embrasures, and getting this to be ready to be restored. Now, this case is going right over to the general dentist, not the same day, but the next day, just so happens. And so I'm going to actually not let it be an occlusion. It's frankly going to be worked on the next day, and there's no sense making the dentist's job harder or to re-upset the interproximal gum tissue. And so you could be a friend when a friend is warranted and just open up the contact altogether and then let the gum tissue have time to sort of breathe and heal. The problem is if they're going to go out to dinner that night, they might get some food caught in those contacts and then still keep the tissues irritated. So that's up for you to sort of consider those talking points. But I always want to think of my referring doctor and what they're going to judge me, see this by, and if I can help them out with what they're doing with the crown, so be it. I'm going to take the steps to do it. I'm 51 minutes, so I'm actually still, within the realm of my protocol. So we're going to, it's sort of my happy trail, but more time-consuming trail. But it works for me because this would be considered a hard endo for me. Hopefully, if fortune would have it, I had an easy endo next, and I'd be done with 30 minutes to spare. And those are called blessings in our office, so that's always a good state. Final check of occlusion. And this, my friend, is about ready for your Q&A. So you can't have it without sort of getting to the end, so we got to show the post-op obturation. But let's just sort of fast forward this and pause.